Hello and welcome again. In this video, we will discuss about different types of occlusal splints, their uses, and how to choose particular splint. So before we discuss about different occlusal splints, we should ask the same question again: why you need to have a splint, why there is a need for splint. Because most of the time when we are functioning, the teeth, we discussed before that the teeth are not in contact. However, the reason we need splint is because teeth occlude. And for some people, they occlude longer and more heavier forces than the other people. And that's why it is important to look at the table we looked at earlier, where the difference between function and parafunction. Because it is so important to understand how the parafunction works before you consider any type of splints. However, as we will discuss later on in the lecture, that the use of the splint is not limited just for people who parafunction. There are other uses as well. So let's look at this table again. So as you can see in the table, when someone's parafunctioning, they are contacting their teeth 10 times longer than people who are not parafunctioning. Not only that, the forces is much higher. The direction is horizontal rather than vertical, which is much more favorable for the posterior teeth. The lever which it's created is class 2, which is much more destructive. The neurosensitivity is less when you're parafunctioning, because usually you're doing another activity and your brain is engaged for that activity, or you are sleeping, which is an activity, and your brain has better things to do than think about how much force you're putting on your teeth. The muscle contraction is also isometric when you're doing parafunction, and the direction is eccentric. It's not really, the jaw is not moving in the same direction as you ask patient to close their teeth, tap, 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 or move their jaw right and left. The jaw moves in all sorts of different directions. And this is something we need to really assess when we're doing clinical examination. And this is something people or dentists gets caught out of when they haven't assessed this properly. And then the movement which patient does when they are doing bruxism or clenching is in a grinding is in a completely different direction than what they are producing in clinical environment. So you really need to look out for those facets and try and see how the jaw moves to get a better understanding how patient may brux or grind their teeth during the nighttime or the daytime. And obviously you have a more pathological effect because of that. So what are the signs and symptoms of patients who are parafunctioning? So if you look at the TMJ, you have pain and limited mouth opening. If you look at the muscles, again, you can get pain or you can get myospasm. If you look at intraorally, you can see rare facets, drifting, fracturing, pain, hypersensitivity of the teeth, which is not settling by normal common treatments. Or if you put any restoration or the previous restoration, again, you see rare fracture or decementation of the crowns. However, sometimes you see patients who don't have these kind of symptoms, obvious symptoms. So how do you know that this patient has a parafunctional activity? One of the ways to know that is by asking them to close their teeth, relax, and try and manipulate that jaw. If patient cannot close their jaw in the same direction easily and have a stable ICP, you can maybe consider going down to route of further investigation for parafunction. It could be that they are wearing dentures for a long time and they cannot really close their jaw properly, or they have really lack of posterior support and they forgot to how to close their teeth properly. So there are different reasons, but this is one of the reasons where you see the warning signs before you do full mouth reconstruction or before you do more heavy restoration. The other sign is you can see multiple broken teeth or fracture restorations. If you see that, then you need to start doing more thorough clinical assessment and finding out why these teeth are fracturing, even though they all are heavily filled and they're doomed to fracture. You need to still investigate them, because I've seen many heavily filled teeth intact in some mouth, and sometimes you see teeth which are minimally filled but still fractures. So you need to assess this in more deeper. Or sometimes patient just simply comes to you and says, I have pain in my jaw joint. If that happens, then obviously that's a really warning sign. Now, with regards to occlusal splints, let's look at a definition of occlusal splints. And as you can see in the definition, it's a removable appliance which changes the relationship of maxillary and mandibular teeth, the way they close. And it can be used for various purposes, diagnostic, to treat the temporomandibular disorders, radiation therapy, occlusal repositioning. So the definition almost includes the indications which occlusal splints can be used for, but it's not limited to that, and there are many more uses which we will discuss in future, in further this lecture. So now we know what occlusal splint is. Let's look at the effect of occlusal splints. So occlusal splint is known to reduce EMG activity in nocturnal bruxers. So people who brux their teeth at night time, it reduces the EMG activity. And what that suggests to us is the muscle activity is less when patient brux with the splint in their mouth. And because of that, we can say that it relaxes the muscle and pushes the jaw back into more relaxed position. And then furthermore, it helps in the TMJ area, because the joint is now in positioning or trying to go back into CR, which is, we know that it's more stable musculoskeletal position. So that's how splint helps. And the studies done shows that people who were assessed using pantographic tracings, where, if you want to do a full mouth restoration, we do pantographic tracing for mounting the model on fully adjustable articulator. What we saw that it was easier to do pantographic tracing on people who were non-bruxer, okay? However, people who were bruxer, who had a parafunctional habits, it was difficult to do this tracing. However, when they wore occlusal splints, especially Michigan splint, the pantographic tracing became easier and as good as people who didn't brux. Now, all these studies are biased towards one area or the other. So you need to really look into the whole picture, because many authors have now even questioned the EMG studies, because EMG is not always the best way to measure the muscle relaxation, and there are different other areas which you need to consider. However, it just gives us a simple perspective. The splint is doing something, and no one denies that splint is helping in doing something. It's just how it helps is still not 100% clear cut, because people are different and it works in every different situation differently. So let's look at, if we look at ideal splint, let's look at some of the roles of ideal splint. So one of the role is diagnostic, that you can use the splint for diagnostic purposes. You can use the splint for preventative purposes, which we know aware of. And also we can use splint for treatment reasons. So let's look at the diagnostics. So first thing the splint does is it relaxes muscles and moves the jaw back near or closer to CI position. So if you're trying to record the CI position, it helps if you've given patient a splint, because if you for some reason cannot use deprogrammer or you want to try something else, if you're giving patient a splint, the patient comes back with more relaxed jaw position, or that's actually at least the theory is that the patient will come back with jaw position which is much more relaxed, and you can manipulate that jaw nicely in CR to get a better mounting for your restorative work. The other use of the splint is if you're trying to assess proposed occlusal scheme at increased OVD and you are worried about patient's adaptability, then you can try out your occlusal scheme in your hard acrylic Michigan splint. And this is something I do quite routinely if I feel that patient is a bruxa and got parafunctional activity, and on the first or second visit I'm doing full assessment, I'm struggling to manipulate the jaw. I would make the Michigan splint for patient and let them use that for a couple of months, make sure everything's relaxed before I go ahead with my more further assessment and treatment for full mouth reconstruction. It also helps me to assess patient's compliance, because when you're doing full mouth reconstruction or more extensive dentistry, you want patient to wear some sort of a protective appliance afterwards, especially if the reason why your patient needed full mouth reconstruction or extensive dentistry was wear and parafunctional activity, which is many times is the case. But if patient comes back to you and say, look, I can't wear the Michigan splint, I cannot put anything in my mouth, you need to make the patient aware that our restoration are not stronger than teeth, and the forces you're applying on the teeth, you can easily break the restoration, whatever you put in patient's mouth. So you need to make the patient aware. So it helps you in assessing the compliance of the patient. Now, when you give a patient a splint, what you can do is you can assess the wear pattern, and I will show you later on this video series how to do that assessment. But you can assess the wear pattern, and you can assess really how patient moves their jaw and which teeth are more in contact. And obviously you can use this as a pre-restoration stabilization. So before you are doing full mouth reconstruction, you want to stabilize everything. You stabilize it, give patient Michigan splint, and that helps in relaxing muscle and breaking down the treatment as well. So the other use is preventative. This is something we know very well, that it prevents further wear and tooth surface loss, which is happening because of the grinding, clenching, or bruxing. It doesn't prevent the tooth surface loss due to daily activity, acid erosion. So I always tell my patient that I will give you splint, but it will only protect against the bruxism or tooth-to-tooth contact issues. However, it will not protect you if you're eating something acidic, or if the dentine is exposed considerably. It will still keep wearing down even though you're wearing splint, because you're not going to wear splint 24/7. You're going to take the splint out, use your teeth for normal functional activity, and because of that, you need to educate patient that it is for preventative, but it's not going to prevent 100% of the tooth wear. So this is very important. So it also obviously protects, as we discussed, your newly restored teeth. With regards to treatment, it helps in management of TMD where occlusion is the main factor. And this is, I cannot stress enough that if the occlusion is not the main factor, the splint will help, but you really need to assess what are the other factors which is relating to this pain or problem. And in general dental practice, again, I'll go through later in this video, that you need to make sure that you assess the patient carefully, which patient you would like to treat and which patient you would like to refer, depending on your experience. The stress-related pain, which symptoms derived from hyperactivity of the muscles, the splint will help, because what it does, it distributes the forces, and because of that it reduces the muscle activity. It also helps in trauma from occlusion cases, such as there are some mobility with some of the teeth. If you're finding this and if you want to give patients a particular type of splint, make sure that you make the splint on the same arch where the tooth is being affected. So let's say if the lower right 5 is being affected because of trauma from occlusion, you want to give splint which is covering that tooth and protecting it. You don't want to give Michigan splint on the maxillary arch, which is still going to give some load to that tooth. Even though it's more distributed, it will be less load, but there will be still some load. It is also used for dental pain associated due to occlusion. Again, we discussed that there are some areas where patients have a non-functional contact or non-working side contact, and you want to temporarily take that contact out. You can use Michigan splint, and that helps with dental pain as well. If particular tooth in pain or patient's pain with particular tooth, you make sure that you give the splint on the same arch. If you give the splint on an opposite arch, it may not be as effective. It still will be effective, but it may not be as effective. So let's look at the types of the splint. And I want to make one point clear, that this is not an all list of all splints available. There are numerous variations available in each and every splints. However, these are some of the splints which we can come across. So one of the commonest used splint is soft splint, which is with the full coverage. Now, this splint is very commonly used because it's easy to make, and we'll discuss about that in a minute. The other type is you have a hard full coverage splint with either a flat plane or the guidance inbuilt in that. You can have anterior repositioning appliance or mandibular advancement splint, which is also called as mandibular orthotic repositioning appliance. The other splint is an anterior midpoint stop appliance or NTI-TSS splint. You have posterior biplane, pivoting splint, B-splint, and hydrostatic splint. So let's look at them one by one. So first one is soft full coverage splint, and this is a go-to splint for general dental practitioners who wants to give something quick fix to the patient. I've used it as well, and I still use it in very selected cases where I want something very quick, immediate to give it to patient. However, what it does is it protects for a while, but you cannot adjust the splint, and that's why it doesn't help with particular cause. But if patient doesn't have any parafunctional activity and just want to protect your newly restoration from potential parafunctional activity, then you can give this type of splint. However, be aware, because some of the case studies or research shows that this splint can cause parafunction because it's a rubber, and patient can it can give you a chewing gum effect, which you keep chewing it. And that's why it's very important to avoid giving this type of splint for long-term use. However, I know some patients who are using these splints and quite happy with it. In that case, they can continue using it and you continue monitoring them. Now, other type of splints are full coverage hard splint, and these can be a flat splint, or it can be a Michigan or a Tanner splint. Now, when you have a flat splint, they are used for just a stabilization, but if you incorporate some sort of a guidance in the splint, which is you do that for Michigan splint and Tanner splint, what it does is it creates the idealized occlusion, which is removable, so it's a reversible manner. So you can take the splint out and patient back to normal. So you can give patient an idealized occlusal plane without having to cost them too much money. It guides the condyle in CR again in most musculoskeletably stable position, and that can help you in mounting your model or relieving the pain. It reduces the trauma from occlusion, as we discussed, by redistributing the load. It reduces jaw joint pain of the muscle, again because of the distribution of the load, and because it has a guidance built interiorly, it moves the forces away from the joint. And we know that if you have 100% of the force at the posterior molar, you have around 60% of the force at the cuspid area, and around 20% in the incisor area. So I'm moving the force away from the muscles and reduces the muscle activity. It's one of the use of Michigan splint is that you can try or test out your occlusion using this Michigan splint. So you can build the occlusion that you want to, and you can use and test the occlusal OVD, increase of OVD in the patient where you're worried that they might not adapt to the particular situation. And as we say, it temporarily eliminates the interferences, and you may wish to do that for patient who are bruxing but doesn't want to do any treatment. Tooth is normal, natural, healthy tooth, but having some pain in the muscle, give the patient Michigan splint, and that does help. Now, the other type of splint is anterior repositioning appliance. Now, this is a directive splint. So there are two types of splints. You have a directive and non-directive splints, or permissive splints. So permissive splints allows patient to move their jaw in all the direction they can move. So it doesn't really inhibit them from jaw movement. It may direct or guide them, but it still allows them free movement in the way they want to. And that's why Michigan splint is permissive splint, or flat occlusal splint is a permissive splint. However, the anterior reposition appliance is a directive splint because it's directing the mandible to move forward, because patient cannot close their jaw in the normal position they used to close when they close in ICP. It just moves the mandible forward into forward position, and what that helps is moving the jaw joint forward and reduces the pressure on the jaw joint, and that allows the capsule, the ligament, to recover. And this is used in specific conditions when you have disc displacement with reduction, and we'll go through about this in detail, how to use this splint later on. The other type of splint is anterior midstop appliance, which is also called NTI at TSS. This is a very simple appliance. It comes pre-made. You just reline inside with the acrylic and put it in patient's mouth. It locks in really well. You can then adjust the anterior ram to make sure it's parallel to the occlusal plane of the patient, and you give this to patient. And what it does is it removes occlusal interference because there is no posterior contact. It also allows freedom for full seating of condyle, so it's permissive splint. It encourages release of the lateral pterygoid muscles and releases the pain. So it's a really good short-term appliance. However, my concerns are that if you use it for long-term, which patients sometimes, if you give it to them, they just go and never return, and because the pain's gone, everything's fine, patients like it. Then if patient uses it for a prolonged time, then there is a supra-eruption of the posterior teeth can happen. You can have some mobility on the lower anterior teeth because all the load is going on the lower anterior teeth. Or worst case scenario, patient, if it becomes loose, patient can swallow or inhale it, and that can cause issues. And because of that, I tend not to give this type of splint to patients to wear it at night time. You could use them as a deprogrammer. However, I particularly don't use them for nighttime use. However, if patient cannot really cope with it, then you might want to look into cope with the Michigan splint, then you might want to look into alternative options. The other directive splint is mandibular orthotic repositioning appliance, which is using posterior plane, bite plane, to move the jaw forward. And again, this is to move the condyle away from the jaw joint to give more time for recovery. You can make this type of splint with a flat plane, so it allows mandible to move around. And these type of appliances with the posterior bite raising have been associated with better sports performance, better physical performance. However, there is no link whatsoever to suggest that they do that. However, they do cause posterior intrusion if worn prolongedly. The other splint is pivoting splint, again with the same principle, where patient has just one point of contact on posterior molar, ideally first molar, which allows mandible to pivot and come away from the socket, again to help the healing of the socket. There is not much evidence on this splint, and that's why it's not used that frequently. However, it helps in some cases, it doesn't in some cases. B-splint is a dual arch splint, so again it's only anterior contact. However, it covers all the teeth. It covers the maxillary and mandibular teeth. And this is useful when you want to give anterior repositioning appliance, but you're worried about orthodontic stability of the teeth. So you can give them this retainer B-splint where you have upper and lower full coverage, so there is less chances of supereruption, and still you get the anterior contact touching. Then we have a hydrostatic splint, and this is almost becoming obsolete. The concept was that you have a water-filled, bilateral water-filled plastic chamber. So when patient closes onto the splint, it adjusts according to patient's bite. And because of that, it allows muscle to relax. However, there is no evidence whatsoever on this splint working. It was invented by Lerman in 1974, but again, there is not much great research out there on this splint. So we looked at all the different types of splints. However, the current preferred option by most of the clinician authorities is maxillary splint, which provides full coverage, such as Michigan splint or tenon splint. Although when I say authorities, I know some of the very good authorities describe different type of splints. So it's very much divided what splints is used in what situation. Everyone has their biases. So you need to look at all the evidence with a pinch of salt and make sure that you use whatever works in your hand with the evidence. What I would say though is the commonly used, the shortcuts used by not using Michigan splint, because Michigan splint or hard splint is more expensive. Patients sometimes cannot afford it, and sometimes you resort to a soft bite raising appliance. Just be careful that you cannot adjust them. Patients are aware of it, that you cannot adjust them, and it only prevents tooth wear from the bruxism. However, it may cause some other issues. So if you need to use it for a short term if you can. Monitor it and see if it's not causing any issues, patient's happy with it, using it, it's working, okay, you can use it. However, just it needs to be monitored like any other splint. So the question arises that how do we choose from all these potential options of splint? Now, as I said before, you need to make a decision what splint works in your hand. However, I will go through my simplified diagnostic criteria and how I use it in general dental practice. If, as I said, discussed before, again and again, I would say that if you think that patient's coming with a pain which you cannot really manage and it's looking something beyond your remit, it is better to refer a patient which may not be suitable to treat in general dental practice. So first of all, diagnosis is the key. As we discussed, you need to really assess what is the reason you're giving this patient a splint. So if I'm using splint for diagnostic purposes, preventative purposes, or cases where a patient has pain and disc displacement without reduction, I would give patient Michigan splint. Now, if patient has disc displacement without reduction, and if you have someone who is more experienced than you, or TMJ specialist, as if there is a term, then you should refer patient to them. However, in my experience, surgery is the least resort, and the area where I work, it's very difficult to refer a patient to somewhere else because there is no expertise available. So I tend to treat these type of patients with Michigan splint, and they tolerate moderately well. So, it gives them some pain relief. You need to reassure them that, the mouth opening will recover slightly. It takes time, but it will recover. It may not recover fully, but it gets better and better over the time as the ligament stretches and jaw becomes used to with that position. If, however, patient has disc displacement with reduction, then this is one of the cases where I use anterior repositioning appliance for, let's say, 4 to 8 weeks, assess patient again. If patient's in pain, I would leave the patient with the splint for some more time because it can take some time before the retrodiscal tissue adjusts. And then once patient's out of pain, I would then put the patient onto Michigan splint. And this is the criteria I use to treat my patient. And this is how I have divided different types and make it simplified to use it in your general dental practice. So you only need to really know about Michigan splint and anterior repositioning appliance. Yes, as I said before, you can use different NTIs, NTI-TSS or B-splint or soft splint, which are one of the three of the most commonest other splints being used, and there is nothing right or wrong about it. However, I feel giving Michigan splint give patient a better occlusion. You can do a lot of more thing with Michigan splint which you can't do with other splint, especially when you are planning to treat your patient doing a restorative treatment. So I hope this lecture was useful. In the next video, we will discuss about different steps and the procedures you need to do to fabricate Michigan splint.